Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome back to the channel of Stand Medical Notes. So I had said in the last video that we will discuss the vascular diseases from this video onwards. We have discussed about the cardiac part, but the vascular part we have not discussed. So let's begin the vascular part from today, from this video. So in that, the first one and the most important, the most common thing which we see and the most important pathology which we see in almost all people, it is systemic hypertension. So there is something also called as, I mentioned it as systemic hypertension because there is something called as pulmonary hypertension. Okay, pulmonary hypertension. So to differentiate from pulmonary hypertension, that is nothing but increased blood pressure in the pulmonary vasculature, in the right, what do you call, if this is the heart. Okay, divide the heart in the right part and left part. This is left part and right part. This left part will supply the blood to whole of the body, whole body, to the brain, to the major vital organs and everything. This left part supplies the blood to the lungs. So this is known as the pulmonary circulation and this is known as the systemic circulation. So any increase in blood pressure in this circuit is known as the pulmonary hypertension, and this is systemic hypertension, which we see in majority of cases. Pulmonary hypertension develops in patients who have pulmonary fibrosis or right heart failure or pulmonary arterial hypertension. Many causes are there. COPD patients. Okay, so let us discuss about systemic hypertension. So as the name suggests, it is systemic. So it affects whole body. It affects whole body. So definition of systemic hypertension. General definition: sustained elevation of arterial blood pressure above a threshold where treatment reduces cardiovascular risk. Okay, so a threshold that should be sustained, the blood pressure should be elevated persistently at a threshold. That threshold should increase the cardiovascular risk. If the blood pressure moves above the threshold, it increases the cardiovascular risk. That is known as hypertension. Okay, it is not merely a number. Previously what we used to do is we treat the numbers by using antihypertensive drugs, but now the perspective has been changed. It is not just treating the numbers, but it is the treatment to reduce cardiovascular risk. So that is the main goal today. So the perspective has moved from this to this. So just mere treating the numbers to reducing the cardiovascular risk. This is the main goal today, to treat the hypertension. So reducing the cardiovascular risk, that is the main goal of hypertension, and the guidelines which are coming are based upon this only, based upon the cardiovascular risk only. Okay, so this thing we should bear in the mind. And there are different guidelines. There are American guidelines, there are European guidelines, there are British guidelines, other Indian guidelines, other. So guidelines are differ the threshold. Why? Because different guidelines give different threshold. Why? Because the risk of the cardiovascular risk increases above SBP of more than 115 millimeter of mercury, 115 by 85. So above this SBP by DBP, only the from this threshold only the risk of cardiovascular will increase. So that's why the guidelines are differ in giving the threshold for where should the patient be treated. If you take this as threshold, then everybody has to take hypertensive drugs. If you give more threshold, then cardiovascular risk will be increased. If you give less threshold, then more number of patients will be recognized as hypertensive and more treatment will be, over treatment will be given. That's why the guidelines differ in giving the threshold. So that's the basic concept we should know. So the traditional cutoff in most guidelines, that threshold is, what is that? This threshold is nothing but our main aim is to reduce the cardiovascular risk. Okay, so the most guidelines, according to most guideline, office BP should be equal to or more than 140 by 90 mmHg, then that is known as hypertension. 140 equal to 140 by 90 mmHg. Okay, most guidelines give this threshold. Okay, high normal or pre-hypertension ranges are below this threshold. For example, 130 to 140 by 85 to 90 is considered as pre-hypertension. For example, like pre-diabetic, which can develop diabetes later on. So similarly to that, pre-hypertensive ranges. So some guidelines give this 130 to 140, and some guidelines give 120 to 130 as pre-hypertensive range. But just remember this point: this traditional cutoff which most guidelines give is more than or equal to 140 by 90 mmHg. If you are getting this range of BP according to the method, proper method by which you measure the BP, for more than at least more than two visits the patient should have, for at least more than two visits, then you should consider the patient as hypertensive and you should start the hypertension drug. This is office BP. What is office BP? The clinic BP. Clinical BP, the patient, the BP which the patient has in the clinic, that is office BP. There is something called as home BP. So the patient, the BP which the patient has in the home, that is home BP. Okay, office BP is nothing but the patient, the BP which the patient has in the clinic, that is office BP. So this is the guideline. So this is the level 140 by 90. Okay, so according to the American Cardiology Classification or American Heart Association 2017 guidelines, stage 1 hypertension is defined as 130 by 80. I said no. So Americans are taking 130 by 80 as the threshold. Sorry, 130 by 80 as threshold to treat the hypertension. 130 by 80. Americans are taking this, and they are considering 120 to 130 by I think 75 by 80 as pre-hypertensive. So this is the American guideline which is considering now, so that any patient which is having 130 or 80, okay, 130 by 80, that patient should receive antihypertensive drugs. So this is the only one guideline which is giving this range, but most guidelines give 140 by 90. Okay, so we will discuss later on, many things are there, just we will see the guidelines now. So European and British guidelines give the cutoff of 140 by 90. So based upon this only we are treating the patient. So this is actually office BP, what we are discussing, office BP, nothing but clinic BP. So ambulatory or home BP thresholds are different. Ambulatory is nothing but the patient has some machine which is continuously recording the BP of the patient, and the patient is doing the daily activities. So average of that BP is taken as ambulatory BP. Okay, that is ambulatory BP. Home BP is the patient is measuring the BP in his or her home. That is home BP. So the threshold for that is slightly lower. That is 135 by 85 mmHg. 135 by 85 mmHg. Okay, so we have discussed these things. So what is office BP, what is ambulatory BP, what is home BP, everything. So there is something called as isolated systolic hypertension. So just systolic BP is raised, but diastolic BP is less than 90. So this type of hypertension is seen in elderly because of stiffening of the arteries. So the arterioles mainly the aorta gets stiffened in the elderly patients. So because of that, the systolic BP is raised. Systolic BP is raised in the elderly. So this is known as isolated systolic hypertension. There is something called as isolated diastolic hypertension. Isolated diastolic, where the DBP is raised, but the SBP is not raised. SBP is equal. Okay, so this type of hypertension is seen in young individuals. Okay, so isolated diastolic BP isolated diastolic hypertension is mainly seen in young hypertension, whereas isolated systolic hypertension is mainly seen in elderly patients. That's the thing we should remember. Okay, so that's about this table. Okay, let's move forwards. So what is epidemiology and what is the global burden? This is very important. We take it lightly to understand that this is a slow poison which kills the patient. Okay, very important. See here, it is a leading contributor. Why? Systemic hypertension is the primary modifiable risk factor for cerebrovascular accidents, nothing but stroke, brain, myocardial infarction, heart, congestive heart failure, chronic kidney disease, kidney, and one more important organ you can take it as eye, hypertension retinopathy. So these, the heart, brain, kidney, okay, the leading modifiable risk factor which is causing these diseases is nothing but hypertension. So if you control this modifiable risk factor, so you can control strokes, you can control heart diseases, you can control kidney diseases. So that is very important thing. Okay. And next, so global prevalence, approximately 25% of the world's adult population according to 2000 data, it was 25%. According to 2025, it is 30% of the world's adult population are having BP. What is the trend? So expansion is predominantly in economically developing regions. Why? Because of westernized lifestyles. So technology is developing, people are becoming lazy, and they are lazy, and they are taking, their intake is high. So technology is developing, but people are becoming lazy. That's why they are getting, this is nothing but westernized lifestyle. They are getting this hypertension. So high sodium intake by food and physical inactivity and rising obesity. So these patients, high sodium intake and physical inactivity and rising obesity, they have a very high risk of developing hypertension. Risk relationship, continuous log linear relationship between blood pressure and cardiovascular risk. I said no, starting at 115/75 mg only. So the risk starts initially only 150/75 only. That's why the guidelines differ. So at what threshold you should treat the BP. If you give the anti-hypertensive drugs at this BP, then almost every individual should have anti-hypertensive drugs. So that's why the guidelines differ. So American are giving 130/80, and most other guidelines like British and European, they are giving 140/90. The latest one is this only, 130/80. If someone is having 130/80, equal to or more than that, you should treat that patient. So some physicians follow this guideline, some physicians follow this guideline. We will see when we should. One more thing we should understand is that when we should use this American guideline and when we should use this British guideline or traditional guideline. So the patient with comorbidities, remember this. I will just remove this all thing. So one important thing I want to say. So when you should take this. So 130/80 is one thing, 140/90 is one thing. So patient with comorbidities like some heart disease, angina, or adults more than 50 years, or you can take in nowadays 40 years, okay, and some having kidney disease, or some stroke patients, or some COPD patients. So patients who are having the comorbidities, or patients who are having cardiovascular risk of more than 10%, which is calculated by some calculations like Framingham score or Prevent score, which we'll learn in the later classes. So if the patient is having the cardiovascular risk more than 10%, or if the patient is having the comorbidities, then you should use the American guidelines to start the antihypertensive medications. And if these things are not there, if the patient is not having the comorbidities, the patient is young, and the cardiovascular risk is not more than 10%, then you should use this one, 140/90, as the cutoff to start the BP. So this is very important point, which I want to explain. So risk increment. Each 20 mmHg increase in systolic BP and 10 mmHg increase in diastolic BP doubles the risk of death from ischemic heart disease and stroke. Remember this one, very important. Each 20 mm rise in SBP and 10 mm rise in DBP doubles the risk of death, okay, by increasing the risk of stroke and heart disease. Prognostic indicators. Historically, DBP was considered the important prognostic indicator, but today's understanding is that the systolic blood pressure and the pulse pressure is nothing but a difference between the systolic blood pressure and diastolic blood pressure. These two things, SBP and pulse pressure, are stronger predictors, especially in individuals more than 50 years. Okay, systolic BP and pulse pressure are stronger predictors of risk than the diastolic blood pressure. One thing you can remember, diastolic blood pressure is stronger predictor of risk in young individuals. Whereas systolic BP is stronger predictor in elderly individuals. So this point we can remember. So that's about this table, very important table. Everything is important. Okay, so this 15 days I have done research, I have seen many books, and I have consolidated the information in this manner. So age related hemodynamic patterns, we should understand this thing also. So first two decades, nothing but the first 20 years of life, up to 20 years. First two decades is nothing but up to 20 years. BP is linked to growth and maturation. This is a normal development change, and it is a physiological adaptation during growth. First 2 decades, BP will increase, and it is a normal change. Okay, it is an adaptation. But adults between 20 to 50 years, nothing but less than 50 years, there is progressive rise in both systolic BP and diastolic BP, or also isolated diastolic hypertension. I said no, diastolic hypertension is seen in young individuals, nothing but less than 50 years. So SBP less than 140 or DBP more than or equal to 90. This is nothing but isolated diastolic hypertension. So there is progressive rise in SBP and DBP in young individuals, nothing but less than 50 years. What is the reason? There is increased peripheral vascular resistance with compliant arteries. Okay, because the vascular, remember, diastolic BP is nothing but the peripheral vascular resistance, and this peripheral vascular resistance is provided by the arterioles. Okay, so these are compliant, means they don't lose their elasticity. These are compliant. So compliant arteries, their diameter is decreased, but they are still compliant. So because of decreased diameter in these compliant arteries, or you can say increased peripheral vascular resistance with these compliant arteries, the DBP is increased. Okay, more, and but overall SBP and DBP both are raised. So peripheral resistance increase in the setting of compliant conduit arteries. So arteries are compliant is nothing but they're still elastic. Okay? They don't lose their elasticity. This is important point. You understand why this is important. Okay. The next thing is, so in individuals who are beyond 50 years, okay, more than 50 years of age, diastolic BP levels off or declines, and systolic BP rises continuously, which widens the pulse pressure. Okay, so isolated systolic hypertension more than 140 or equal to 140 mmHg is more common in more than 50 years of age. Why this is common? Because age related stiffening of the large arteries, like aorta, reduces the systolic cushioning and diastolic sustainment. So this is the reason why we are getting isolated systolic hypertension, because of stiffening. They lose their elasticity. Which arteries? Large arteries. Whereas in the diastolic hypertension, the small arteries, arterioles, they have their elasticity, but still the vascular resistance, means the diameter of those arterioles is decreased. That's why we are having diastolic hypertension in young individuals. Okay, so less than 50 years and more than 50 years. So less than 50 years, you will have increased both SBP and DBP, but DBP more commonly. More than 50 years, more commonly you will have SBP raised. Okay, so the khulasa, means the conclusion, less than 40 years, isolated diastolic hypertension or combined SBP or DBP you can get because of increased peripheral resistance. Between 40 to 60, you will have combined systolic and diastolic because of both stiffness of the large arteries and increased peripheral vascular resistance in between 40 to 60. Whereas in more than 60, you will have isolated systolic hypertension because of aortic stiffening and reduced compliance. So less than 40, diastolic or both SBP or more DBP. 40 to 60, more commonly SBP and DBP. More than 60, more commonly SBP. Okay, so this pattern you should remember. Okay, this pattern. Okay, one more time. So less than 40, both SBP and DBP, but with DBP more commonly in young individuals, but SBP and DBP. 40 to 60, mixed DBP, SBP and DBP both. More than or equal to 60, SBP more common. Okay, this is important to decide the treatment. Okay, and one more thing, why there is increased peripheral resistance in young individuals? This is because Oxford says there is increased activity of Rais, renin angiotensin aldosterone system in young individuals. So this is the reason why there is increased peripheral resistance in young individuals. Increased activity of Rais compared to the elderly individuals. That's why there is increased peripheral resistance in young individuals less than 40 years. Then 40 to 60 and more than 60. Okay. So we will have some classification and diagnostic frameworks. So the diagnostic threshold for hypertension is not a biological constant, but a clinical decision point where the benefits of intervention outweigh the risk of treatment. Recent guidelines, particularly the 2017 American Cardiological Classification or American Heart Association and the 2024 European Society updates have lowered these thresholds to identify individuals at high risk earlier in the disease process. As I said, when you should use 130 by 80 and when you should use 140 by 90. You should use this in patients with comorbidities or increased cardiovascular risk. You should use this when the cardiovascular risk is less than 10% and without comorbidities. Okay, this point you remember, this very important point. Okay, so we will see the comparative classifications now. Standardization of blood pressure measurement is important, requiring at least 2 readings on 2 separate or 2, at least 2. And Davidson says at least 2, Oxford says at least 3. Gap in these occasions, Davidson gives us 1 week gap between the visits, but you can take it as 2-3 days gap also. So at least 2 visits should be necessary, or more than 2 is okay. Okay, this is easy if the patient BP is less than 180. If it is more than 180, then you can't take this point. More than 180, immediately you need to start the antihypertensive. Less than 180, 180 by 110, you should measure the BP of the patient more than 2 visits. Okay, if it is, and you should take the average of those. You should take average of 2 readings in each visit. So in each visit, you should measure the BP 2 times and you should take average of those 2 readings. And if the BP on more than 2 visits, it is more than 140 by 90 or 130 by 80, depending upon the context, you will start the antihypertensive medications. Okay. So now I will go to the classification directly. See, this is the classification. So this is the American classification and this is the European and British classification. In this one thing is there, US guideline, I will say what it is. So European, American classification classifies BP as normal is less than 120 by 80, elevated is 120 by 30. This is known as high hypertension or pre-hypertension. Okay. So 120 by 130 less than 80, this is elevated. Stage 1 is 130 to 140, 80 to 90. Stage 2 is more than 140 and more than 90. Now, this was American. Now coming to the European classification. So optimal is less than 120 and less than 80. Pre-hypertension or high normal is between 120 to 140. See the difference. Here it is in American, it is 120 to 130, but in European guidelines, it is 120 to 140 actually, not 130. Okay. And 85 to 90. Grade 1 is 140 to 160. See here, stage 1 is 130 to 140. Here it is 140 to 160, 90 to 100. And grade 2 is 160 to 180, 100 to 110. Grade 3 is more than or equal to 180, more than or equal to 110. So this is how much difference is there. Okay. In the American and European classification. Okay. So I think it is enough for now. So I said when to use American classification and when to use this traditional European or British classification. It depends upon the context in which your patient lies. Okay. I think it is enough. For in the next class onwards, we'll discuss about the pathophysiology of arterial pressure, means hypertension. This is very important for understanding, so that many drugs are there. Which drug you should give to your patient. So that depends upon your understanding of this pathophysiology of hypertension. So that we will discuss in the next class. Thank you.